Today's topic that I have chosen for my dear students and medical officers, it is osteoarthritis. In the first part, we'll be discussing about understanding the osteoarthritis and its concept. So let us start with the medical definition of osteoarthritis. It is said to be a degeneration of the joint cartilage and the underlying bone, which occurs most commonly from the middle age onwards. And it is a progressive form of arthritis that is characterized by breakdown of the cartilage in the joints. It represents a heterogeneous group of the conditions. The ultimate result is in a common histopathological and radiological changes. Old concept was that it is a degenerative disorder which results in the breakdown of the articular cartilage in the synovial joint. The current concept, osteoarthritis, involves not only the articular cartilage but also the entire joint, including subchondral bone and synovium. Let us see how it is different from the inflammatory arthritis. In osteoarthritis of the weight-bearing joint, the loss of the joint space usually occurs in the areas with the highest loads, whereas in inflammatory arthritis, there is uniform joint space narrowing. Is it a non-inflammatory disease? Usually it is classified as a non-inflammatory arthritis, but the evidence shows that it is not a true non-inflammatory disease. And the reason is cytokines and the metalloproteinases are released into the joint, and these agents are involved in the excessive matrix degeneration that characterizes the cartilage degeneration. Also, the researchers have found increased level of IL-17 in the synovium of the osteoarthritis, and this IL-17 is also found in the synovium of the rheumatoid arthritis, which is an inflammatory disease. Is it correct to term it as a degenerative disorder? So there are evidences which is contrary to that. There is an evidence which suggests that it is due to the abnormal mechanics more often than the degeneration. Inflammation occurs as a cytokines that we have seen, and also inflammatory IL-17 levels are increased in the synovium. That also is an evidence that it is not a true degenerative joint disease as well. So, terming it as a degenerative joint disease is no longer appropriate for the osteoarthritis. Can there be a biomarker to know progression of osteoarthritis? Many researchers have come out with the idea that the serum uric acid level can predict future joint space narrowing. They have found that the people who were having serum uric acid level less than 6.8 milligram per deciliter, their joint space narrowing was 0.31 millimeter, whereas the people who have got serum uric acid level more than 6.8 milligram per deciliter, their joint space narrowing was almost 3 times that of the previous one, and it is about 0.90 millimeter. And these authors suggest that the serum uric acid levels may serve as a biomarker for the progression of the osteoarthritis. Of course, further studies are required to confirm it. Remember, this is not a biomarker for the diagnosis. It is a biomarker for the progression of the osteoarthritis. The joints affected most are predominantly weight-bearing joints, which includes knee, hips, and spine. There may be other non-weight bearing joints which may be affected, and these are the distal interphalangeal joint, proximal interphalangeal joint, and carpometacarpal joints. The classification is very simple. It is either the primary or the secondary. Secondary osteoarthritis refers to the osteoarthritis that results from a predisposing condition that has adversely altered the joint tissues, especially trauma to the articular cartilage or the subchondral bone. It also means that there has to be a cause for the osteoarthritis, and usually it occurs in relatively younger individuals. Whereas primary osteoarthritis, it is a bit more nebulous. It is idiopathic phenomenon occurring in previously intact joints having no apparent initiating factor. Many of the clinicians, they want to limit the term primary osteoarthritis to the joints of the hands, which are non-weight bearing, DIP, PIP, and the carpometacarpal joints. Many of the orthopedicians, they do believe that most cases of the primary osteoarthritis that we see in the hip, it may be due to the subtle or sometimes unrecognizable congenital or developmental defects. Is there a clinical difference in the primary and secondary osteoarthritis? Yes, there is a little difference. The primary osteoarthritis is usually bilaterally symmetrical, whereas there is no symmetry in secondary osteoarthritis. There are some subsets of the primary osteoarthritis. It is primary generalized osteoarthritis, erosive osteoarthritis, chondromalacia patella. Let us understand a little of the anatomy of the joints. So joints classification we base on two parts. One is either functional or structural. The functional classification is usually based on the movement of the joint. And based on the movement, there can be three types of the joints: synarthrosis, meaning immovable; amphiarthrosis, slightly movable; and diarthrosis, freely movable. On the structural classification, it could be synovial joints, fibrous, and cartilaginous joints. The osteoarthritis occurs in the synovial joints, and the structures in the synovial joints are articular cartilage, subchondral bone, synovial membrane, synovial fluid, and joint capsule. Must be remembered, all of them are affected in osteoarthritis. How the osteoarthritis is progressing and what are the changes that is occurring, that is interesting to watch. So in initial phase of the osteoarthritis, there is usually swelling of the cartilage, and it occurs because there is increased synthesis of the proteoglycans. It actually is an effort of the chondrocytes to repair the cartilage, and it can last for years. There is a damage and hypertrophic repair continuing in the cartilage. But as the osteoarthritis progresses, the proteoglycan level eventually drops, and it causes cartilage to soften and lose elasticity. Microscopically, flaking and fibrillation occurs in the cartilage. Fibrillation is the vertical cleft, whereas flaking is on the superficial surface. Over time, the loss of the cartilage will happen, and radiologically it is seen at the loss of joint space. The erosion of the damaged cartilage progresses till the underlying bone is exposed, And when this bone is exposed, it is denuded of its protective cartilage, and then it responds by vascular invasion and increased cellularity. Thereby, it becomes thickened and dense. This process is known as hibernation. As the osteoarthritis progresses, there will be cystic degeneration in the subchondral bone. And what is the cause? Cause are twofold. The theory is that it is due to osseous necrosis, secondary to the chronic impaction or chronic overload, or it can be due to intrusion of the synovial fluid. Synovial fluid is under great pressure. And there are some other names of the cysts, which is interesting to know. It is also called subchondral cyst, pseudocyst. European doctors most commonly call it as geodes. Osteoarthritic cysts in the sternum are termed as Egger cysts. The size is from 2 to 20 millimeters. Why are the osteophytes formed? The osteophytes are usually seen along the articular margin, and cause is vascularization of the subchondral marrow is occurring. There is osseous metaplasia of the synovial connective tissue, and ossifying cartilaginous protrusions all combined lead to irregular outgrowth of the new bone. What are the joint mice? They are intra-articular loose bodies. So intra-articular loose bodies are also called joint mice. And what are they composed of? It can be due to the fragmentation of osteophytes, or articular cartilage itself may result in the presence of intra-articular loose bodies. As the osteoarthritis progresses, are ligaments also affected? Yes, it can be affected. Most commonly, it's seen in the lateral collateral ligament, especially when there is a varus deformity. Let us understand why there is pain in osteoarthritis. What is the source of pain? It is multifold. It can arise from osteophytic periosteal elevation due to vascular congestion of the subchondral bone, thereby leading to increased intraosseous pressure, synovitis with activation of synovial membrane nociceptors, fatigue in the muscles can cause the pain, joint contracture, joint effusion can cause inflammation of the periarticular bursae sometimes, and they can contribute to the pain, and periarticular muscle spasm can contribute to the pain, and there may be added psychological factors. The spine can be involved, and if it is involved, usually it is in the L3, L4, and L5 segment most commonly seen. And when there is a osteoarthritis of the facet joints, it can cause foraminal narrowing, thereby compressing the nerve roots. It can also cause acquired spondylolisthesis. Causes for the primary, it is age, obesity, family history, reduced level of the sex hormones, muscle weakness. Repetitive use must be remembered. It means jobs requiring heavy labor and bending, and we can make the patient understand how to prevent or lessen the progression of the osteoarthritis. Diabetes mellitus is one of them, to name a few. The secondary OA, few important causes can be infection, crystal deposition, previous inflammatory arthritis. Usually we see in the burnt out rheumatoid arthritis. Could be hemoglobinopathies, could be underlying risk factors as in congenital hip dislocation, And one point which must be remembered is the previous meniscectomy. Meniscectomy causes osteoarthritis. Why advancing age affects the joint more often? And there are several causes of it. With advancing age, the reduction in the cartilage volume happens. Also, the reduction in the proteoglycan content, reduction of the cartilage vascularization, and cartilage perfusion. Also, it has been seen that senescent cells accumulate in many tissues, and these senescent cells are age-related. They come with the age-related pathologies. There may be hereditary component involved, and it has been seen one gene, which is MCF2L gene, which is associated with the osteoarthritis of the large joints. Is genetic testing a solution to predict future OA or to individualize the therapies? Currently, the clinical genetic testing is not offered to the patient unless they are suffering from the disease with a genetic condition. But in future, testing may allow individualization of the therapies. The volume of the problem is voluminous. 32 million individuals in the United States. And figures are also very much influenced by how the condition is defined by medical professionals. Should we define it by self-report? Should we define by radiographic criteria or symptomatic criteria or all of them? Let us see the radiographic criteria for the osteoarthritis. If it is taken into view, more than 50% of the adults older than 65 years are already affected by the disease. The age-related demographics still say 80 to 90% of the individuals older than 65 years have evidence of osteoarthritis radiographically. The prevalence of the disease increases dramatically among persons older than 50 years of age. The individuals who are older than 55 years, the women outnumber the men. And in women, usually the DIP joints are affected more often. And they have OA knee more than the men. And women are more prone to erosive form of the osteoarthritis. There are some pathological progression which is occurring in the osteoarthritis, and it is divided in 3 stages. Stage 1 is proteolytic breakdown of the cartilage matrix is occurring. Stage 2, fibrillation and erosion of the cartilage surface develop. And stage 3, breakdown products of the cartilage induce a chronic inflammatory response in the synovium, which in turn contributes to further cartilage breakdown. So we come to an end of our part 1, that is understanding the osteoarthritis. Thank you very much. Go through the video a few times. I'm sure you will be competent to answer the questions put forth by externals and internals in the examination. Thank you very much.